ideas. Like Daniela mentioned, this is not a really research paper. It's a point of view or a direction of research. And the idea behind this was to try to translate some of the ideas from the basic neuroscience and motor control to a clinical practice. And by doing this, we identify some problems with this transfer, and I hope we provide one of the possible solutions how these ideas can be used in a clinic. At this point, there are several papers and several discussions on the state of neurorehabilitation. There are some promising evidence that the treatments, the clinical, on the effectiveness of the clinical treatments for upper limb rehabilitations, but unfortunately, the levels of this recovery are not complete. Also, several randomized clinical trials recently published showed maybe disappointing results, disappointing in terms that they do not show any advantage of novel treatments when compared to typical standard care treatments. Now, the explanation for it might be either really these novel treatments do not provide anything extra over the typical standard treatment, or maybe the clinical outcomes that are being utilized in randomized clinical trials are not sensitive enough to identify the underlying changes or recovery or compensation. In the literature and also in the area of neuroscience, there's a growing need for clinical outcomes that are based on the basic research on ideas from neuroscience and motor control. And one of these kind of outcomes, possible clinical outcomes measures, might be movement quality. When movement quality has been defined as coordination among joint muscles, joints, different motor elements that are organized in a specific way by the central nervous system at the performance level, ensuring accurate and stable and adaptable movements. So one of the key features of movement quality are stability and coordinations that are very crucial in tasks of everyday motor actions. The stability and coordination, they allow individuals, healthy individuals, to continuously changing their and to continuously adapt to a changing environment, and for example, to resist unpredictable external perturbations. So the movement quality, the use of movement quality as a possible outcome measure can provide us more detailed information on how a person accomplishes a functional task, but also it does not focus only on the performance level. It focuses on how different motor elements involved in that movement, just like I mentioned before, muscle activation, muscles, joints, forces, digit forces, how they contribute and how they are organized to make sure that the task is being performed on the satisfactory level. This more detailed information about the possible recovery compensatory strategies can be used to guide clinical decisions, maybe to improve individual treatments, and also to track progress of recovery and compensation over time. But more importantly, this kind of clinical outcome would be based on the ideas and theories of motor control and movement neuroscience. So in the area of motor control, there's been a well-established framework of uncontrolled manifold analysis that was very compatible with that definition of movement quality. There's a lot of articles and reviews using this framework of work. And during this discussion, I'm not going to go too deep into the computational details of that analysis, I'll refer you to this article by Mark Latache and others, and there are other articles with details of this procedure. I'm just going to highlight here more basic understanding, more basic ideas behind this framework. So if we imagine a task when we have a patient sitting in front of the computer and we ask this patient to press with two index fingers from the left and right hand on these force sensors, that will generate a force, total force level. Now, when we ask, we show the feedback of the total force on the computer screen, and we ask a patient to generate a specific level of force, then again, by pressing of these force sensors, patient can get to that required level of force. So on the screen, as you can see here is the computer screen, we can ask a person to follow this force pattern on the screen, and then at the required force level at the steady state, we can capture at this specific point of time what is the contribution of the left and right index finger forces. So then we can represent this task on this two-dimensional graph. On the x-axis, we're going to have a force of the right index finger. On the y-axis, a force of the left index finger. And then this dashed line will represent at the target force level, a required force level, exactly at this red point. So when we ask a patient to do this once and we take a snapshot at this point, we can put this one point right here, and then we see that at this point of time, a patient generates a slightly more than 10 newtons of force because it's away from this, it's above the dashed line. And we can see that the left index finger generated a little bit more force than the right index finger. And then when we repeat this task again, we're going to have a slightly different picture. Now, patient generates a little bit less than 10 newtons of force overall, and maybe with more equal contribution of both fingers. Then after 3 trials, we're going to have, again, slightly more 10 newtons, but with a small error, and then again, slightly different contribution of index forces. So after, let's say, after 16 trials, we're going to have this kind of set of data, cloud of data, that represents variability between trials for that specific task. So performance variable here is the total force at 10 newtons, and elemental variables, or motor elements, as we call them in the paper, index right and left index forces. Now, as you can see, in a typical UCM analysis or experiment, this data cloud has a specific shape. The data are mostly elongated along or parallel to this task or solution line with 10 newtons, which means that the patient is exploring different solutions to the same task. Because as you can see, anywhere on the dashed line, if the point is on the dashed line, anywhere on this dashed line, the total force is always 10. However, different position of the dashed line will represent different contributions of fingers to this task. So this is the direction that is sometimes called uncontrolled direction, because in theory, this direction where is the most, there's the least stable, or the central nervous system does not need to control this direction, because anywhere along this line, the performance variable has been accurately represented. Now, in the orthogonal direction to this line, perpendicular to this direction, we have changes that will directly affect the performance variable. So if the point is above this dashed line, that means the subject performed more than 10 newtons, and if it's below, it means the subject will perform less than 10 newtons. So this direction is the direction we can think about, the direction of the error variability. So if it's not on the line, but it's above or below, there will be some sort of error. But in typical tasks like the one that presented here, the data is elongated along the UCM. So then we can get some parameters from this data cloud. We can look at the magnitude of the variance along this dashed line, which is called variance along QCM, or sometimes it's called in literature good variance, because this one does not affect performance variable. And there is a direction orthogonal to it, so variance orthogonal, or magnitude of that variance. And sometimes it's called bad variance because it directly affects the performance variable. So any movement in this direction away from the dashed line introduces the error. So based on this analysis, we can estimate a couple of parameters, and three most popular are variance along QCM, variance along orthogonal, and so-called index of stability, which is simply a normalized difference between VUCM and VORT. Now, on this slide, I showed you 16 trials of the steady state, snapshots taken at a specific time. But we can apply exactly the same computations to look at how these parameters change within the movement, the trajectory of the movement. So here's going to be a short video. I hope you're going to see it over Zoom, but the task is exactly the same. As you can see, so this black thin line represents a required force level. So a subject, by pressing with two fingers, has to get to this force level, then achieve a steady state, then at this specific time, suddenly increase the force, the new force level, and stabilize at the new steady state. So we have a total force on the y-axis. Here is a time on the x-axis. This picture here is exactly the same I showed you before. The data is just the mean, so all my points are at the center of the screen, but we have a Newton, so force of the index right, force of the index left on the y-axis. Again, this dashed line represents the performance variable, the mean. And these two column bars here represent variance along UCM and variance along orthogonal. So I'm going to try to turn this video on and showed you what happens. So individual black dots represents separate trials as well. But now we see how this cloud changes over time with within trajectory of that movement of that task. Again, each point is a different trial. These trials are aligned. Now, as you can see at the steady state, so let's say stop here, this is steady state, you can see how these forces of the left and the right index finger forces align with the solution space of the older performance variable. And there's a very small amount of variance orthogonal, so there's a small amount of error, but this person, every trial experiences different solutions to that task. Now, just before the task change, or at the moment of the changing the task, oops, I knew it's going to happen. So it's going to somewhere here. You can start to see that now the task change. Instead of stabilizing the task at the steady state, now the patient or the subject has to change the task. So now it has to destabilize the task in order to get at a new level. So now you're going to see during this transition phase and destabilization, this data cloud now is elongated along the orthogonal direction. And then after some time, when we get to a new steady state, again, you can see this data cloud looks more what I showed you before, the elongation along the UCM direction, so exploration of different possible solution to the same task. So UCM analysis can be definitely used as a tool to measure movement quality because it quantifies two important aspects of movement quality. First of all, it quantifies neural organization of motor elements such as digits, muscles, to stabilize performance. And we quantify these by computing UCM parameters, again, index of stability, magnitude of variance along UCM or VORT. But also, we can look at the adjustment or modulations of performance stabilization when needed. So when we need to prepare to the sudden task change or expected task change. And these adjustments in the neural organization are in the literature called anticipatory synergy adjustments. Now, Again, there's a lot of literature out there, and you see here one of the references that show that these parameters are successful in distinguishing or differentiating healthy controls from neurological populations. So these parameters and these calculations can discriminate between healthy population and the population with some neural disorders like strokes or Parkinson disease. Now, here is the problem that we think limits the currently application of UCM in a clinic. So here are three theoretically possible families of results from UCM experiments. When we have a purposeful neural organization of elements to stabilize the task, we're going to see that variance along the UCM is larger than the variance along orthogonal. So that's the picture, that's the graph on the left. So right here, I'm sorry. Here, that's the graph on the left. And in this situation, the index of stability, because it's normalized difference, delta V should be larger than 0. Now, when there's a purposeful or destabilization of the task, then V or the variance along orthogonal is larger than VUCM, and index of stability is less than 0. Now, the assumption is that if there is no purposeful control, there is no purposeful coordination of these elements, then you're going to have just the random distribution of these data points without any covariation, and then these two directions, or the variance in these two directions, will be equal. Therefore, index of synergy will be equal to 0. However, in practice, this is not the case. So here are a couple of examples of simulations using random data with no covariation in it. So we just put random numbers with known mean and standard deviations into the computation, and we simulated 20 trials of UCM experiment. And you can see that just by a chance, we got a data cloud that looks like something collected from a subject with UCM variance way larger than the ORT, and therefore index of stability is pretty high, 1.2. Now, in the consecutive simulation using similar surrogate data, we can have just by chance VUCM lower than VORT. Now with the index of synergy less than 0. Of course, by increasing number of trials to, let's say, up to 1,000 of these simulations, our data cloud starts to look more and more what we should expect from the theory, so more and more circular. Then VUCM magnitudes are become closer to VORT, and delta V values, or the index of stability, becomes closer and closer, go asymptotically approach 0, what we should see. But of course, we cannot have experiments, especially in the clinic, we cannot have testing protocols that include thousands of trials. We usually use 20 trials, around 20 trials. That's the most common in UCM analysis. So in a typical application of UCM, researchers use cohort study design to compare magnitudes of the UCM parameters between groups or between conditions. And this allows, it is allowed to identify different motor control strategies in different conditions or between different groups, for example, patients and control groups. This involves statistical tests to evaluate differences in the magnitudes of the UCM parameters. Now, the problem here again is that we cannot use the same approach in the clinic when we want to test as single patients. We want to test as individuals without having a big cohort study and without having control groups. So what is again, what's the problem here? One of them is, so how confident are we in the calculated UCM parameters? How do we know that delta V at the magnitude of 1.2 is the real representation of behavior of the subject? Or is it possible that this number was obtained just by pure chance? And another question is, how can we use the UCM analysis to a single person in a clinical setting when we can only afford, let's say, 15 or 20 repetition of the task, and that's it. We cannot have the full-blown research protocol. So we employ a bootstrapping simulations. And again, I'll try to avoid going too much into details, but this is the general approach what we did. So we, let's say we have a single person that repeats a task 16 times. Then we take the data and resample from that experimental data randomly with replacements. So what it does, we maintain the number of observation, but we reshuffle the values. So for example, we take a finger force from the trial 1 and we match it with the finger force from the other hand from the trial number 10. So basically what it does, it destroys the covariation structure in this data. Then in that first step, we calculate the UCM parameter. It might be, like I mentioned before, index of stability, VUCM or VORT. And then we repeat that resampling with replacement, let's say 1,000 times or 10,000 times. So what we have at the end, we have this resounding distribution of UCM parameters from randomly selected motor elements. This represents possible UCM parameter magnitudes from data that has no covariation, or like with the destroyed covariation. So then, based on that resampled distribution, we can identify 95% confidence intervals. Here are they represented with these red lines. So now we go back to our original data. We run a typical UCM analysis on that one person. We have one UCM parameter, and now we can compare this UCM parameter to these identified confidence intervals. So if this UCM parameter is outside of the confidence intervals, then we can say that we are 95% confident that this experimentally obtained UCM parameter reflects a real behavior of a subject, or there is a covariation structure that represents a neural organization. So if this value is above upper limit of confidence interval, that is a purposeful stabilization of the task. If this value is below the lower confidence intervals, that means there's purposeful destabilization of the task. Okay, I have a few more minutes. I'm sorry, a little bit late, so I'll try to speed up. So we tried to apply this idea of bootstrapping on data from individuals from previous publications. So now I will just show how we apply this method to different functional tasks and different neurological populations. So in this first example, I took a data from one person and one pair from the experiment that we used to test different motor control strategies when passing an object from hand to hand. There were so the object was instrumented with 4 sensors. We passed the object from hand to hand of the same person, that's a lone task condition, or the object was passed from one hand to another hand of the different person. That would be a shared task or 2-person condition. So we took one individual performing this task alone, and we took another set of data from one pair performing this task together. Now, the performance variable here is the rotational equilibrium of the handle. We ask subjects not to move the handle and not rotate the handle. So in a mechanical terms, what it means that the net moment applied to this object should be 0. So that when the net moment of the top hand and the bottom hand, they should be equal to 0. And this dashed line here represents more or less the 0 net moment. So again, this is the picture I showed you before, but now the blue dots represent trials of the single person performing this task alone, and the red dots represent this task performed by a single pair. Now, in this paper, what we found out that indices of stability, the delta V values, were positive in both conditions for alone and shared task, and there was no difference between the groups. So we concluded that in both conditions, people stabilize the rotational equilibrium um, because they were all positive and there was no difference between groups. However, if we apply a bootstrapping method to this data, we have a slightly different picture. So the top graph shows experimentally obtained delta V value for one person condition, as you can see, 0.75. And then when compared to the bootstrap distribution of this value from its own data, you can see that it's above the upper limit of confidence interval. So here we can say that we are 95% confident that this positive delta V describes a real behavior of a subject. That means the person really tried to stabilize the rotation of the handle. Now in the two-person condition, the delta V is still positive, but it was within the confidence intervals. Let's say we're not confident that the observed value represents a true behavior of that pair. So we cannot say that we saw the emergence of neural organization of elements to stabilize the handle or this object. So a slightly different conclusion by looking more precisely at this data. So another example, we look at the effect of deep brain stimulation on motor quality in a multi-finger task. In the individual with Parkinson's disease, we reanalyzed data from a 75-year-old patient with Parkinson's disease duration for 14 years. It was on medication. The patient was on medication. Now, the task was a little bit similar to my intro experiment, but now the patient using right hand only, if I remember correctly, and 4 digits, and is pressing on these 4 sensors. And the patient is asked to maintain a force level, and then at self-selected time to make a quick pulse or quick change in the total force. This task, this person repeated the task. There are 2 conditions in test, one with deep brain stimulation of basal ganglia and one without. So DBS on and DBS off, and each condition was repeated roughly 20 times. So what we see here on this graph after our analysis confirm the results from the previous published data. So first of all, we can see that roughly 250 milliseconds before the self-selected task change, there was a drop in the index of synergy. On the y-axis, we have magnitude of the index of synergy. On the x-axis, we have time in milliseconds. 0 represents the self-selected time of the force change. And you can see that the drop starts roughly 250 milliseconds before the onset of the change. Now we repeated exactly the same computations as in the paper. So then in the condition without the stimulation, you can see these synergy, anticipatory synergy adjustments or drop in the magnitude of the stabilization process. It's shorter. It starts less than 100 milliseconds before. So this shortening of ASAs in the Parkinson's disease patient has been described before. And here we can see a positive effect of deep brain stimulation because it elongates this time and it becomes more similar to a control group of healthy subjects. So there's no news here. And as you can see, these are the confidence intervals for both conditions. And all these indices of stability are well above them. So that means it represents a true, there is some specific covariations. There is a specific behavioral central nervous system that increases the stability of the task. However, when we look closely at individual components of index of stability, so VUS and VOR, we can see using our approach effects of deep brain stimulation that were not detected previously. So first thing we can see at the bottom graph that these trajectories here dashed and the solid lines, they represent V-ort magnitude. So the magnitudes in this beta direction. They're all well below the lower level of confidence intervals, both for DBS off and DBS on. That means the patient purposefully decreases the total force variability. So they're trying to be as accurate as possible in each trial. So that's good. That shows that they are this is the purposeful behavior, and these values were not observed just purely by chance. Now, the DBS effect, or with the DBS on, we can, first of all, we can see there is a large increase in the variance for the DBS on condition, but this variance mostly goes into the VUCM direction. That means that after DBS, patients do explore different solutions to the same task. Or we can say that we can see the emergence of multi-finger coordination after brain stimulations. You can see this solid line is above the upper limit of confidence intervals. Whereas without the brain stimulation, the variance UCM is still within the confidence intervals. So it does not show the purposeful multi-finger coordination. So this is something that we were able to show using the bootstrapping technique. And the last example, we look at the partial synergies to start multi-muscle synergies to stabilize center of pressure trajectories in individuals with Parkinson's disease. And again, we reanalyze previously published data. We just select one patient with Parkinson's disease and one healthy control. During this experiment, researchers recorded EMG data from the lower extremities and linked changes in the EMG signals or electrical muscle activity to the changes in the COP. And they look how these changes in muscle activities affect changes in the COP trajectory. We selected one patient with Parkinson's disease and one control subject. What's important here that this one patient with PD had no clinical symptoms of Parkinson's disease. It was stage 2 or less than 2, so no partial symptoms for Parkinson's disease. And again, what we, I'm sorry, I forgot to mention what the subject was doing. So one subject was standing on the force plate. We record COP trajectory and muscle activations, or the previous researchers did. And then and the subject is holding a load in the extended arms. And then at the self-selected time, they drop the weight. So what this does, of course, it changes the center of mass distribution, and it causes a sudden disturbance or perturbation to the posture. So the subject has to react to. So again, on these graphs, you can see on the y-axis, we have indices of synergy. On the x-axis, we have time in milliseconds. 0.0 time represents the time of the weight release, which is right here. The top graph represents a control subject, a healthy subject. And again, here you can see the first continuous or consistent drop in the index of synergy. These are our anticipatory synergy adjustments, and it starts to drop down, and it starts to drop roughly 150 milliseconds before the perturbation, self-selected, self-induced perturbation, but it becomes lower than the lower confidence interval around 100 milliseconds before. This subject shows a healthy anticipation to that perturbation, and the central nervous system starts to prepare for it by decreasing the stabilization processes that stabilize the test, because now we need to change the test. We need to react to perturbation. Now, the patient with Parkinson's disease never showed this behavior. There was a consistent drop in the index of stability, but at the moment of the load release, and it never goes below the lower confidence interval. That means we cannot precisely say that what we observe here is the purposeful destabilization of the motor or performance variable. So maybe this is not surprisingly, maybe that's a better word. Surprisingly, our approach shows that in the steady state, none of these subjects showed significant stabilization or destabilization of the task, but only healthy controls show as a destabilization of the task before the perturbation. And this coincides with the previous publications as well. But now we identified that only control decreased the index of stability below the lower level of confidence interval. But like I said before, overall, these results do support the findings of the original study, but we show that we can get additional information by applying bootstrapping simulations. So my recommendations, because I think it's time to finish this presentation and give you some more time for questions. We have several recommendations as you can read in the paper, but here the novelty of our approach is by combination the UCM analysis with the bootstrapping simulations. So that's what's unique about our approach. And we hope that this will help translate or to help the use of this framework in a clinic where we need to be able to have clinical outcomes that can be used on a single patient level. Also, I think I convinced you that we show that this approach also allows us to identify some of the aspects of motor quality that were not identified before. And this might be a good start to trying to translate the UCM framework into a clinic. It might be beneficial in, for example, looking at the motor quality of a patient at different stages of the recovery process. And finally, of course, that is just the beginning of this road. And in the future studies, things like the number or the optimal number of trials need to be answered. And also, now we have a tool to validate the number, but we need to know things like what's the minimal clinically important difference. So, for example, if the index of stability will increase from 1 to 1.5, is a meaningful change or not? So things like that need to be addressed in the future as well. Well, first of all, I would like to thank Dr. Ali Falaki, Dr. Hanjin Zhou, and of course, Professor Marta Dash for allowing us to use data from the previous publications. This our study would not happen without your support, so thank you very much. And this study was funded by University of North Georgia as well. And if you have any questions, I'll be glad to answer. But if you want to...
Everyone coming back, this was an experiment. So now I think that if you had a chance to have some productive discussion, I encourage you to share with the group anything that you think would be relevant.
Yes, there was, yes, I had some very interesting questions. And one I think would be very, very frequent comment or question, and this is something we address in our article after some reviewers asked for it, how it can be applied in the clinic, like technically, is it feasible to have this kind of tools? Because it might seem maybe too complicated to do this in the clinic. But I really feel like currently we have a lot of options. We have a lot of low cost sensors, different sensors, force sensors, inertial units, EMGs that you can measure things pretty accurately and use them as a basis of different markers. I gave this example of biofeedback of EMG sensors the clinics use. Clinics use postural stability assessments with rebalance platforms when they look at the center of pressure. I haven't mentioned about kinematics, but you can apply exactly the same ideas for reaching, pointing movements, where you measure rotations of segments with inertial sensors. Very popular right now is assessing muscular fatigue based on EMG, which is not really easy. If you have to program it by yourself, it's based on Fourier transform. But if there is a button in a software that will generate a report, then it's easy. So I think these are technical aspects that can be resolved pretty easily. I think the most important thing is just to follow the regular procedure and trying to work on and introduce markers in a clinic that are based on actual knowledge. I was talking about what was the real motivation behind the study. And I said that with Daniela and Marius, we had a lot of discussion that when we see these very nicely designed randomized clinical trials, when researchers try to assess these novel treatments, but then the first clinical outcomes that they measure are things that are not based on neuroscience or motor control, quality of life being one of them. But when you look just on the trajectory of the movement, or you look at the perceived strength or pegboard test, you're not
Can I respectfully disagree with this?
Sure.
Because the point of an early phase clinical trial might be to look at the neurophysiology or some precise measure like this. But the point of the later phase definitive trials, which are reviewed in the article that we wrote that you cited, the point of those is to improve patients' functions in daily life. And so this tool is maybe great for research studies, may or may not eventually make it into the clinic, but it's not going to tell us if someone can get dressed better, they can take care of their child, they can walk across the street safely, those sorts of things. So I don't disagree with the tool, but I do disagree with your characterization of particularly the definitive later phase trials and the outcome measures not being appropriate.
Yeah.
Stan, can I add a little bit?
Sure.
So I guess my thing about having a measure of movement coordination, I totally agree with the point of Catherine Lang, because I think that when we are actually with your patient in front of you, you can realize that it's like there are other levels of complexity that one has to address as a clinician. But then I think that to use as an neurocorrelates with neuroimaging, I think that there are like some layers that we have to cover as well, to have measures that are more, or measures of quality of movement and movement coordination that are closer to maybe to the neurobiology, neurophysiology. And I'm not saying that maybe this measure it is, but that's kind of like the discussion that I think it's important to have as well, because when you talk about dressing, like how can you relate that to what the brain is doing? And, like, I think that we have to discuss that. So if somebody else wants to make comments.
Yeah, just to answer this comment, I agree that different levels of things that we're interested in, what's the purpose of neuro rehab. I just want to highlight this one of the results that we show, that we have a patient for this partial stability study that was asymptomatic. So there was no identified clinical symptoms, right? So, but with this tool, we are still able to distinguish his motor behavior or his posture control from a healthy subject. So I understand at different levels. All I'm arguing is that we need to have some tools that may be more precisely looking at the process of the recovery or of the treatment, that are even more sensitive to these changes, even before we can see it in the clinical picture. But it's.
Stan, maybe I can add my 25 cents. So I understand your point, and I understand Kathy's point, and I don't think that there is any contradiction between the two. There are tools, and in particular these tools, that are sensitive to very small changes or to preclinical changes or to things that the patient doesn't feel and the clinicians do not detect during their regular examination. And that's great to have such tools, because they promise early detection of the disease. They may inform physicians on preventative medicine or neuroprotective medicine, rather than addressing the problem when it's already full blown and it is seen clinically. However, Of course, Katie is right that what patients care and their caregivers care is whether they can dress independently, take care of themselves, and so forth. These are a different scale of magnitude phenomena. And so they require different tools. And that's, I don't see a contradiction between the two. I think that developing a sensitive tool to subclinical changes or to preclinical changes is a very good and noble exercise in itself. Not to say that it may be informative about the brain mechanisms involved, although we're not at that stage yet. So, well, that's my 25 cents.
Thanks, Mark. Anybody else wants to make comments?
So Mark, thank you very much for the comment, and sorry I'm having a discussion with you without vodka in the room. That being said, I think that
I have some in my room actually. I can.
Well, if you can channel it this way, that's fine. I think that the point of being able to detect subtle differences or predictors of change in folks who appear to be asymptomatic still shares in common the notion of looking at the inherent variability in performance, no matter what the task. Some of the tasks that I had to leave for a few minutes, some of the tasks I saw were relatively straightforward and somewhat simplistic. But what if we posit the hypothesis that the variance that we see within and across individuals is representative of their nervous system? And if we believe in this conceptualization of personalized care, or personalized medicine, personalized rehab, perhaps embracing those differences helps us to define what can be done optimally for an individual, as opposed to this concept of trying to pare everything down into some kind of common denominator. And I think that underlies a lot of what we need to look at in terms of relationships of changes in physiological parameters, how they may be predictive of the functional reacquisition of a person, given where that individual is starting from, and use that information as the basis of predicting the relationship between function and physiological change.
Steve, I couldn't agree more. The point of all people being different is very well taken. And I believe that what Stan has described for us now is a step in that direction. So he shows that we can study indices of stability, for example, of action, not only across populations to show that some kind of patients are different from control, but for individual persons. And then, for example, for a longitudinal study, you can have for a given person, you can have a baseline, and then you can compare behavior in future tests using bootstrapping techniques, and then claim whether there is a significant, statistically significant trend in one direction or another. So I think this tool may actually be very useful at some point for the person-specific care.
Okay, so I guess maybe Stan, if you want to, do you have any other comments? Anybody else? Because it's 1 o'clock, so I wanted to close. And I have just one announcement. So we're gonna have a break and then resume on the 14th of 2021. And the talk is gonna be with Dr. Rebecca Lothwaite on optimal theory of motor learning. So I'm very glad that this is happening again. And I'm gonna send a form maybe tomorrow, just so then if you wanted to like give your feedback, it's like you can do it. And other than that, happy holidays. And thanks for being here. Bye.
Thank you very much, everyone, for attendance and all the questions and comments. And thank you, Daniela, for organizing this amazing meeting. Thank you.
Mm-hmm.
Thank you.
Ciao, ciao.
Ciao.